Hi, everyone. Welcome to After the Diagnosis, a webinar series presented by the Neuroscience Family Advisory Council here at Boston Children's Hospital. In this webinar series, we'll be talking to our providers and parents about diagnoses that we face and giving a completely different perspective on them. Today, in this episode, we're going to be discussing the very wide spectrum that is spina bifida. We have 4 different participants, each with a different background, and I'm really excited to get to talking with you guys. Let's introduce our participants first and foremost. My name's Dylan. I am the co-chair of the Neuroscience Family Advisory Council and now a clinical research assistant here in the department. Dr. Wharf, I would love to hear kind of a brief introduction on who you are and how you came to be where you are today.
Well, I'm a pediatric neurosurgeon, and my official titles here are I hold the hydrocephalus and spina bifida chair at Boston Children's Hospital, and I'm the director of neonatal and congenital anomalies in the Department of Neurosurgery. And for a long time now, I've been the main neurosurgeon involved in the lives of children with spina bifida that are in our spina bifida program.
Wonderful. Ashley.
I'm Ashley Birch. I'm a pediatric nurse practitioner, and now I specialize in neurosurgery. And in the past 9 years, I've subspecialized my practice in spina bifida and hydrocephalus. So I am the neurosurgery nurse practitioner that goes to the spina bifida clinic and cares for these patients on the inpatient side as well.
Great. Belle?
Hi, my name is Belle Gallant. I used to work in the Spina Bifida program with Ashley and Dr. Wharf, along with a bunch of the other providers. I helped with the clinic coordination and prepping over there. And now I work under Dr. Wharf, and I'm his program coordinator.
Great. And Brian?
Hi, Brian Davis. I live in Charlotte, North Carolina with my wife, Jenna, and my 2 little girls, Merritt and Lane. Merritt is 6 years old. She was born with a rather complex form of spina bifida. And as I'm sure we'll get to in a bit, the complexity of her case is what led us to Boston Children's Hospital and to Dr. Wharf. And we now come up there at least once a year to go to the spina bifida clinic.
Great. So let's dig in. Dr. Wharf, I know, through our education conferences in the department, I've come to understand that spina bifida is kind of this term for a spectrum of multiple different conditions. First and foremost, what are the different types? Kind of what are the main forms of spina bifida? Maybe some rarer ones that you see in clinic. Just kind of curious to hear your thoughts on kind of this spectrum of disease.
Well, it's good to start with what the term spina bifida actually means. It's Latin, and it just means a divided spine. So the spine normally has a spinal canal, and the back part of it is covered by bony arches that we call lamina. And if at one or more segments of the spine, those lamina fail to come together and be fused, there's a gap in the bone in the back of the spine, and that's called spina bifida. A fair percentage of the population has spina bifida that you can find as an incidental finding on an X-ray without any associated abnormalities. They would never know they have spina bifida. But spina bifida is always a part of 2 types of spinal cord anomalies or congenital abnormalities that often go by the term spina bifida. So it makes spina bifida a rather confusing term that we throw a number of things into. The most common type, and what people normally are speaking about when they use the term spina bifida, is a condition that also is called a neural tube defect. The neural tube is in the embryo what the brain and spinal cord is made from. And there can be a point along the sort of zipping up of this tube where that fails to happen and the tube is open. And that is part of the spinal cord that's being formed. When the tube fails to close at one point, in the developing spinal cord, the other coverings that are supposed to come around and come around to cover that also fail to close. It's sort of a domino effect, so that the spinal fluid sac has a defect in it, the bone has a defect in it, that's the spina bifida part, and the soft tissues, muscle, fascia, skin also have a defect, and those children have an abnormally formed bit of spinal cord tissue that is open to air, it's exposed at birth, and those children are immediately at risk for infection, meningitis, and so we repair that and close it early. More importantly, that part of the spinal cord has not formed properly, and so there are various disabilities that go along with that, things that don't function properly in terms of nerve and muscle function. The most common one is bladder and bowel function, because those are the nerves lowest down. And then depending on how high up along the spine this abnormal cord is, that's what determines what other muscles in the legs are going to be affected. So some of the kids are able to walk, the ones with the lower spina bifida defects. Those with defects higher up tend to be the ones that their legs don't work well enough to be able to walk. Those children also have some brain anomalies that goes along with their type of spina bifida, because there's an effect on the brain by having this open tube in the womb. And commonly those children have a condition called hydrocephalus that needs to be treated, fluid in the brain. And they can also have a spectrum of severity in terms of brain, developmental brain issues that can affect their cognitive development. So it's a very complex form of congenital anomaly. So that's quite a common type of spina bifida. It affects about 1 in 1,000 babies. Another type of spina bifida is not one that involves primarily the neural tube, but it affects the way the very bottom part of the spinal cord gets formed. That very lowest tip of the spinal cord doesn't get formed from the primary neural tube that I just was describing. It's formed secondarily after the neural tube closes, and that comes from a group of cells in the embryo that migrate and turn into different tissues in the lower part of the body, including the bottom part of the spinal cord. And when there's an abnormality there, the default type of tissue that forms is fat. And so those children have an abnormal component of the bottom part of their spinal cord that is composed of fat. It's a lipoma. And that lipoma that infiltrates and attaches to the bottom part of the spinal cord itself comes out through this spina bifida defect up to a lump oftentimes underneath the skin, where it merges with the fat under the skin. Those kids also can have abnormal function of those lowest nerves that come off the bottom part of the cord. It can affect their bladder and bowel function. It can affect their lower extremity function. And those children don't get operated on urgently because their skin is there, the skin is formed, but the spinal cord is anchored at the bottom end by this lipoma. And so at some point, we usually do an operation to separate the cord from that fatty attachment and try to free the cord up so it's not under tension, because that can cause worsening problems over time, and that's called a tethered spinal cord. So the open type of spina bifida, the closed or skin covered type of spina bifida, different things with some overlap in the kinds of issues that children face.
So it sounds like, and correct me if I'm wrong, but it sounds like a condition in which, just as the presentations are quite different, the sequelae or the symptoms after the fact can also be quite variable, right? You do have some like common effects across most of these kids, but there is some kind of difference in how children end up presenting after the fact, correct?
Well, Yeah, the main difference between those two is, first of all, one is open at birth and there's a risk of infection and they need to be fixed early, whereas that's not true for the lipomas. But they both have varying degrees of dysfunction of the lower spinal cord with the same kind of problems.
Right.
Bladder and sphincter muscles that don't work properly, some degree of muscle weakness in the lower extremities. There can be orthopedic deformities in the lower extremities that result from the muscle weakness, especially things like clubfoot deformity. The way the children function and the way they look in clinic can be very similar. Another main difference, though, is that children with the lipomas don't have an effect on their brain that the children with the open kind of spina bifida do. So that's also a dividing point.
Absolutely. And then in terms of diagnosis itself, are you guys, seeing children postnatally? Are you aware of, for example, a neural tube defect or lipoma prenatally as well? I'm kind of curious how that flow works, that when you're made aware of a newborn with spina bifida.
Yeah, most of these children are diagnosed before they're born these days.
Okay.
That didn't used to be the fact, but it's much less common now to have a surprise. Fetal imaging is very good. There are also some other laboratory tests that can show signs that there's been a neural tube defect, the worst kind of open spina bifida. But most of these kids are diagnosed prenatally. You can distinguish a spinal cord lipoma from the myelomeningocele open spina bifida. With the open type of spina bifida, the myelomeningoceles, the neural tube defects, some children can benefit from closing that defect before they're born through fetal surgery. The main benefit of that is that it interrupts what's going on with the effect on the brain and can reduce the degree of severity of the brain malformation. We don't do any kind of fetal surgery on the spinal cord lipomas. There will be no advantage to that at all.
Great, thank you. So before we kind of get into the Spina Bifida Center, and we'll touch on Brian and Merritt's story as well, we kind of talked about some differential modes of treatment, right? For the myelomeningoceles, it's about making sure that if it's postnatally treated, that the defect is covered as soon as possible. But Ashley, I'd also love to hear from you kind of on the inpatient side and even the clinic side. What does kind of the care flow look like for a nurse practitioner, somebody, who's working with these patients all the time?
It's a little different for whether you have an open myelomeningocele or if you have a spinal cord lipoma. So if it's an open defect, then, we've started to implement a pathway here where the babies are born and then the care is just initiated, where we have a standard of how we do things. And so the backs are closed and then ultrasounds of the brain start to see if they have developed hydrocephalus. We get the urologists involved right away, and they see these babies as soon as they're born, and the orthopedists. And then we're doing extra things now, and have made it a standard to look at like how they swallow, what their vocal cords look like. We do sleep studies. So that's all become standardized. There are a lot of things because there's brain involvement in these babies with myelomeningocele that we need to do kind of right away. The babies with the lipomas are different, right? Because they're not getting treated till they're about 6 months old. So we still have standards that we do for them, but it's a much different process. They have their surgeries when they're a little bit older. If we need urology, we get them involved, but it's a much shorter course after. And then as far as the Spina Bifida clinic goes, their experiences in the clinic will change based on what they're affected by. So almost all of them see urology, neurosurgery, and orthopedics, but the level to which they need someone will change for each kid. And then they'll see people like physical therapy and the other specialties can come in as well. But the kind of big three are neurosurgery, urology and orthopedics, and most kids see all of them.
And
So
I
it
can't
sounds-
really emphasize enough how important that is, the multidisciplinary aspect of this. We see the children at the same time, and the reason that's important is that these disciplines are all interconnected. For instance, a child who's going along at a certain level of function may start to have a change in that function. It may deteriorate. The bladder may become more hostile, more dangerous for the kidneys, harder to stay dry. The spine might start to curve. There may be orthopedic deformities developing in the feet. And these things are interrelated with the spinal cord itself. When we see those kinds of things, when I'm talking to the urologist, for instance, and he tells me, Ben, there's increased overactivity of the bladder, the pressures are higher, something's changed. That's a big red flag that the spinal cord is under stretch because it's tethered in scar tissue. And we operate on that to release the tension on the cord to reverse those effects. Same for developing scoliosis. There are two very big operations, one spinal fusion and instrumentation for scoliosis, and another one, a big operation called a bladder augmentation. We can often avoid those bigger, more risky operations by untethering the spinal cord soon enough to prevent things from getting that bad. So we're very in tune with what the physical therapist is telling us about the child. We're very interested in what our neuropsychologist thinks about the child. We've just very recently found a child who seemed fine, but the neuropsychological testing was going downhill for age. The child was dropping behind. And as it turns out, that was because the hydrocephalus wasn't treated well enough. And based largely on that, we took the child to surgery and found indeed the pressure in the brain was high, and we had to deal with that. So not only is it a convenience for the patient to come on one day and see all the providers and sometimes get tests like MRIs and bladder testing and so forth, but it's much better care because the providers are seeing the patient as a team, and we communicate not just during the clinic, but outside the clinic about the patients. So it's a really important aspect of their care, is this multidisciplinary center paradigm for care.
Yeah, and I've had the joy of getting to see Spina Bifida clinic in action, and it's amazing, to watch kind of like the informal conversations that just happen around the big table, and making sure that kids are being followed long term, and then there's no kind of lapses in communication just because everyone is right there every Wednesday. It's been fascinating to watch. So kind of switching over to Brian and Belle. Brian, I would love to kind of briefly hear about Merritt's story, and really I want to understand how you explain to a child what Spina Bifida is.
Sure. Yeah. So as I alluded to earlier, she was born with a rather complex form of Spina Bifida, the spinal lipoma that Dr. Wharf has been talking about. She had a procedure here in Charlotte when she was only a few months old to detether her spinal cord. That was not effective. And so her symptoms, primarily bladder dysfunction, were deteriorating, and we couldn't figure out why. And long story short, through the online second opinion program that Boston Children's offered, we were connected to Dr. Estrada in urology. We came up to Boston. He plugged us in with Dr. Wharf, and Dr. Wharf pretty quickly realized that she needed another procedure. So that procedure was really effective. Her bladder symptoms improved significantly, relatively quickly after that procedure, and now we come up once a year to see you all. In some ways, we'd like to come up more, but of course, it's a good thing that we don't have to. But yeah, so that's kind of how we got connected to the program. And as far as Merritt and kind of how we explain what it is to her, it's something that has really happened in phases as she's gotten older. We try to make sure that when we talk about spina bifida with her, that it's organic and it's driven by her and by her questions, rather than us trying to force the conversation. We always try to be truthful with her, but then we also have to be tactful and make sure that what we're saying to her is in a way that she can understand and process. So it's really been driven by her age and then her personality. She's always been very inquisitive and very aware of her surroundings. So we always kind of had a feeling that she would start asking questions sooner than later. Her initial questions generally surrounded her braces that she wears to walk and mobility. And we'd take her to the park and she'd see kids ripping and racing and ask us why she can't run as fast or why she has to wear braces. And so really, we start our conversations with her by explaining that people are different, that differences are okay, differences are normal. The first time we ever said spina bifida to her, we were in the car and she just suddenly said, "Daddy, am I always going to have to wear my braces?" And I said, well, probably so. And then she said, why? And I told her that she had spina bifida and that when she was in mommy's tummy, her back formed differently than others. And because of that, she has some unique challenges. And I think 2 seconds later, she asked for an iPad and a cookie or whatever else and went right back to being a kid. And then as she's gotten older, the questions have evolved a little bit to why do I go to the bathroom differently? And why can't I do gymnastics like my friends can and things like that? And so, we just try to stick with a consistent message, which is that she can do anything she sets her mind to. It just might be a little bit different than her friends. And in a lot of ways, defining spina bifida is easier to her than answering the questions like, well, why did this happen to me? And things like that. And that's what's very challenging. And sometimes we have to tell her that we don't know. But we always include that, people like Dr. Wharf and Ashley and all the other wonderful people at Boston Children's and elsewhere are working very hard to kind of find those answers. And that's very comforting to her and makes her feel very special. Like, these people care about me and they're trying to answer some of these questions.
Absolutely. And Belle, I mean, as somebody that gets to interface kind of with the clinicians and research and wonderful families like the Davises, how is your role? What is your role like, on a day-to-day basis? And how have you kind of found your work?
Yeah, I mean, it's incredible to kind of get to see both sides of it. I mean, I get to work with the clinicians and I used to work with the flow of clinic and just trying to make everything streamlined. I also got to field all of the questions for the families and help them just get everything coordinated and get their trips planned out and answer any questions that they might have. I got to work really closely with the nursing team. So they do have 2 nurse practitioners and 2 RNs that work in the Spina Bifida Center. So the admins work very, very closely with them just to help the families get any questions they need answered. And then when the families do finally get to Boston, it just feels like they get to take a big breath of fresh air and they're like, wow, this is finally the care that, we've been looking to get. And, we have the best Spina Bifida Center in the country and people do come all over the country. They come all over the world to see, just what Dr. Wharf was talking about, a comprehensive explanation of kind of what's going on with their kid. So it's been it's magical in a way to kind of like watch these families come and, they just want answers. And a lot of times they get to leave with those answers and some solutions to what's going on. And it's been awesome to see just both sides of it. And like you said, watching them in the back room really talk through all of these kids, different issues that they're having, whether it's something that's been going on for a long time, or maybe it's something more emergent, has been really, really cool to watch.
Great. So as we wrap up, I'm going to go to my favorite question, which is, if you were to tell a parent or a patient one thing kind of in 1 or 2 sentences, in this case about spina bifida, what would it be? And I love this question because everyone kind of has something different to say based on their experience. But Dr. Wharf, I would love to kind of hear your 1 or 2 sentence. What would you tell to a parent or a patient?
Just because you have some special challenges that are sometimes visible to other people doesn't mean that you can't have as good of a life as anybody else. Everybody has certain things they struggle with. Some you can see and some you can't. Some of the happiest people I've known are people that have disabilities of various kinds, including these kids. So it's not a tragedy. It's not you know, you can have a good life.
Ashley, what would you tell somebody?
I have to follow that. I mean, I would say along the same lines and kind of echo what Brian said earlier, that like the only limitation is the one you kind of like put on yourself, like whatever you set your mind to and whatever the family does to support these kiddos, they can have full, wonderful lives. And they might have some limitations, but they shouldn't let that stop them from doing what they want to do.
Brian.
I think Jen and I were talking about this last night. There's so many things, and we think about it a lot, you know, having been in that situation as parents and what you would say to other parents. And the thing we settled on was not to make assumptions. And that includes both, I mean, assumptions in many different areas. I mean, for example, Merritt's been blowing us away and exceeding our expectations since the day she was born. And so assuming that she won't be able to do something, assuming that she will be able to do something, assuming that she's going to experience XYZ symptom or whatever, don't make assumptions. Just kind of go along with your child, be in tune with your child, and don't set limits for them. The other thing too is don't assume that your care plan is perfect. Don't assume that your doctors are infallible. Doctors are wonderful people, but they're humans just like anyone else, and they're fully capable of misjudging things or missing things. And so I think it's important to look for second opinions, to not assume that everything's right. And also, if your care plan's not working, like ours wasn't with Merit, don't assume that you don't have options, because there are options. And there are, you know, the online second opinion program, like I mentioned earlier. There's lots of options out there. And so don't make assumptions, and just love your child and enjoy being a parent. And we don't think about spina bifida when we look at Merit. We think about Merit, and very, very quickly, I mean, the second she was born, I didn't even think about spina bifida that day. I just looked at her and I loved her, and we love her more and more each day, and we're so proud of her.
Thank you, Brian. And last but certainly not least, Belle.
These are kind of tough to follow. Jeez
I know.
Louise. I mean, I think everyone wrapped it up really well, honestly. I think the biggest takeaway is kind of like, don't set limits on these kids. You know, they can blow your expectations. And like Ashley, Dr. Wharf, and Brian all said, you know, there's alternatives to everything that you want to do. So set the bar high. You can always make your challenges come to life, and you can set those expectations, and, you know, the bar is never too high.
Awesome. Well, thank you all for such a fantastic conversation. Please be sure to head to the Neuroscience Family Advisory Council's website, which will be linked below, for more resources and information. And stay tuned as we announce more after the diagnosis episodes on more neuroscience topics. Thank you, guys.